Hi, thank you for joining me today. Again, it's Rachel Curtis, the Desert Doula with Ask a Birth Professional. It's a nice, crisp, brisk morning here in El Paso, so I'm in a really good mood, and I'm also really excited about our topic today and our guest. So I'm talking with Dr. Emiliano Chavira. He is board-certified in Obstetrics and Gynecology with a subspecialty certification in Maternal Fetal Medicine. He completed his training at LAC+USC in Los Angeles, California, and he continues to practice in the Los Angeles area. In his years as a specialist working in tertiary referral centers, he has cared for some of the most complicated and high-risk pregnancies, dealing with both maternal medical issues as well as complex fetal problems. His passion is to provide objective and caring guidance to his patients with the aim of instilling knowledge, understanding, empowerment, and hope in difficult circumstances. In addition to caring for complicated pregnancies, he also has an interest in ethical dilemmas in modern obstetric care, particularly as related to vaginal breech birth, multiple gestations, and VBAC, vaginal birth after cesarean. So how excited are you now? I'm super excited. So, okay, I will turn it over and just start off with Dr. Chavira. What is maternal fetal medicine? Break that down for us.
Good morning, Rachel. Thanks for the invitation. So it's funny you ask that, because when people ask what I do, I always end up with this struggle that what people tend to understand is the term high-risk pregnancy, but I really hate that term, and I'll explain why in a moment. So invariably, I end up saying, well, you know, I'm a maternal fetal medicine specialist, and I get this look kind of like, eh. And so then I try again. I say, well, you know, some people call that perinatology, and then the head goes the other way and goes, So finally I give up and I say, I do high-risk pregnancy. So then the light bulbs turn on. They say, oh yeah, high-risk pregnancy. Of course, then what happens is they start volunteering what they conceive of as the high-risk pregnancy, and they say, does that mean like when the mom is old? And I'm kind of like, not so much. But so yeah, maternal fetal medicine really deals with kind of special areas in pregnancy that are sort of beyond just a normal healthy mom with no issues. So that could potentially be, you know, moms with various different medical conditions. Sometimes it could be babies that have birth defects that that you need to pay attention to, or sometimes it has to do with very complicated circumstances on labor and delivery. Maybe mom is having a, you know, significant complication, or there's something going wrong with the pregnancy, and usually the OB doctor then will involve a maternal fetal medicine specialist. So, so that's what I do in a nutshell.
Okay, so let's talk about high risk. What are your? Why don't you like the term?
You know, this one of the things that I've really observed over the years of doing this is that during pregnancy there's a tremendous amount of fear, and it's on all sides. You know, there's fear in the mom, in the pregnant woman, and there's fear on the side of the providers, and that could be nursing staff, it could be the OBs, it's everybody involved in the pregnancy. There's a lot of fear, and I think the term high-risk pregnancy kind of feeds into the fear cycle, because it's just a very scary sounding term. And the other thing about it is it doesn't have a definition. It's very poorly defined. I mean, there's some categories that easily fall into this high risk category. You know, so common things are like moms with hypertension or diabetes, could be moms over a certain age, ranging all the way to things that I really consider high risk pregnancies, which are, you know, significant, you know, heart disease or lung disease. Things that really make, you know, a pregnancy a lot more, you know, riskier, complicated. Most of the stuff that gets called high risk, really, the majority of these pregnancies are going to go well, and maybe the chance that there's going to be some kind of complication is just slightly higher compared to, you know, moms that don't have these issues. But when you use the term high risk, you know, it's what exactly does high risk mean? Like, how high is the risk? And that's completely undefined. So then you basically have an emotional sense about what that means, and it sometimes communicates, I think, that things maybe are more likely to go wrong than they are to go well. And in the vast majority of cases, that's not true. That despite this high risk label, things are most likely to go very, very well. And so I think it's just it's just kind of an emotionally charged and very poorly defined term. So that's why I don't like it.
Yeah, and I feel like, I don't know, parents don't really distinguish between, they're not thinking about, you know, some of the more extreme cases, like, you know, when there's heart defects or something like that. It's like, oh, I have gestational diabetes, and suddenly they're just in this group that's, yeah, like you said, anything can go wrong. And, you know, I don't know, in my opinion, fear doesn't tend to help the labor process. So
yeah, the other thing that happens is it leads people to do things that are actually not in the interest of, you know, helping the pregnancy and helping the baby, because there's this sense that the pregnancy is very delicate, and people will ask me all the time. They'll say, "Doc, so since this is a high risk pregnancy, would you say I probably should, you know, kind of take it easy?" And you know, they're thinking that the pregnancy is very delicate, and they want to, you know, limit their activity. This is very common, when in fact the opposite is usually true. Like if you use the example of a diabetic mother, the best thing for her is, you know, healthy diet and a lot of exercise. So, you know, this concept, oh, my pregnancy is high risk and it's delicate, you know, may lead you to think I should just, you know, kind of be really careful and be gentle with myself and lay around all day, when actually the opposite is true. You should be, you know, out there getting exercise and physically active. So it also, you know, the way you conceive of the pregnancy is, it sometimes leads you to, you know, inappropriate actions.
mhm. And we do lots of testing and things like that. And I feel like you get more tests if you're considered high risk, and more tests can lead to more, I don't know, interventions, more fear and all that kind of thing.
Sure. Yeah.
Okay, so what term do you prefer then for some of the scenarios that are currently just lumped into this big high risk group, but maybe aren't terribly complicated in your estimation? So things like multiples and, yes, VBAC. Do you consider VBAC high risk?
Yeah. So great question. What's the alternative term? You know, honestly, I spend a lot of time just trying to eliminate the term high risk pregnancy from the conversation. And people will ask me, is my pregnancy high risk? And I tell them, honestly, it's not a useful term. They throw everybody into this bucket and just forget about it. And rather than lumping people into groups, I try to really talk to people on an individual level. And rather than giving some, you know, label, I really don't like the emphasis on risks. So, you know, one of the things that happens these days is we're all aware of these very little tiny risks of very, you know, severe bad outcomes, and there tends to be an obsession and a heavy focus on these really rare risks. And so you have big groups of people who are all obsessed with something that is only going to happen in very rare cases. And I think it's much more useful to have a sense of what are the things that are likely to happen, and and the, you know, all the risks. Like, it's important to keep those in the conversation, but also to put into perspective, well, actually, how high are these risks? So, for example, VBAC, I would say that, you know, if you ask your average obstetrician, they would say, yeah, a woman with a prior C-section, that's a high-risk pregnancy. And if we're going to do a VBAC, that's a high-risk birth. I really, you know, I take a different perspective. So if you compare the woman that has a C-section to the woman that does not have a prior C-section, there are certain potential complications that could happen in the pregnancy that would not happen to the woman that does not have a prior C-section. So for example, in labor, that scar could open up. That's a thing you don't usually have to worry about in women that have not had a C-section. There are some rare cases where the placenta attaches to that old C-section scar, and it attaches in a very abnormal way such that it's not going to detach at the end of pregnancy. And so these are some complications that really increase the chances of something going wrong during the pregnancy, that the mom that doesn't have a prior C-section, she doesn't really have to worry about those things. So in that sense, you could call it a high-risk pregnancy. However, it's, in my mind, it's sort of an apples to oranges comparison, because when the mom gets pregnant, basically her reality is that she's got a C-section scar. And at the end of the pregnancy, she's going to have to deliver the baby one way or another. So it doesn't make sense to compare her to the woman that does not have a C-section, because it's just not her reality. So really the comparison that needs to happen is, well, what is the difference between making an attempt at a vaginal birth versus going for a repeat C-section? And the great news is, whichever direction the mom chooses, the risk that something bad is going to happen is actually very low. It's low with a planned vaginal birth, and it's low with a planned C-section. Of course, there are complications in either direction, and you talk those out to kind of help the mom decide which way she wants to choose. But there was a big conference that was held at a national level at the NIH, and they reviewed all the literature related to VBAC, and this was done a few years ago. And one of the things that came out of this conversation was that women who make an attempt at vaginal birth, on the whole, even taking into account the complicated births where it's complicated by the scar opening up, the chances of having some sort of adverse event or complication is actually lower in the moms that make a trial at vaginal birth. Because most C-sections go well, but occasionally there are complications from that, and on rare occasions, very serious complications. So, if somebody's going to call the VBAC a high-risk birth, you're comparing that to the mom that doesn't have a prior C-section. And that comparison just doesn't make sense, because this mom does not have the option of not having a prior C-section. She's got a prior C-section. So the only choice she has is between a trial of a vaginal birth or a planned repeat C-section. And if you make that comparison, it becomes difficult for me to label the vaginal birth as high risk, because in the end, it might actually be safer than the planned C-section.
Wow, you just blew my mind. Because it's so true. I mean, that seems, on one hand, it's very simple and makes total sense, but that's just not how it is. I mean, that's not the choice. And you're right. These mothers with prior cesareans, this is not the choice they're facing. And so that actually segues really well into my next question, which is about informed consent. And these mothers with prior cesareans are going in, and a lot of the ones that I talk to or know, or these stories that I hear, it's not presented to them that way at all. It's not like, well, now you have this choice between a trial of labor or a repeat cesarean, and let's talk about those and weigh them. I mean, a lot of times that choice is, there's really only one offered as a potentially safe option. So would you mind talking a little about what informed consent means to you, and what are the things specifically about risks on the side of a repeat cesarean that maybe women aren't being told?
Absolutely. So your introduction is, to the problem of informed consent is absolutely correct. As a maternal fetal medicine specialist, I spend a lot of time doing consultations on patients who have their own OB, so they're getting their prenatal care with their own, OB doctor, and then some issue comes up and they get sent to me for consultation, and it could be a maternal condition, it could be a fetal condition, and so as a result, I end up having conversations with lots and lots and lots of moms, and this is in different neighborhoods around Los Angeles, and I kind of get the same story everywhere, which is it's very, very common for a mom with a prior C-section to essentially be told that once you got a prior C-section, then your next pregnancy is going to have to be another C-section. And very often they're just, quite frankly, not given the option, and there's no discussion about their options. There's no discussion about the pros and cons. And very often there'll be a very misleading conversation that if you were to try a vaginal birth, it's very dangerous, and they really harp on the risk of uterine rupture or the scar tearing open in labor. And they paint a very grave picture of that scenario and say, therefore, we're just going to schedule you for a C-section. And they spend typically not 3 seconds talking about the risks related to cesarean delivery. So that kind of ends up implying that the C-section is a zero risk alternative, which absolutely it is not. And there's a big confusion in obstetric care related to the issue of informed consent, and the way a lot of hospitals and nurses and OB providers conceptualize informed consent is they conceptualize it as a piece of paper with the patient's signature on it. So if the patient signs, she has given her consent. And in fact, that is absolutely not what informed consent is. And this is not the Dr. Chavira definition. This is the definition of informed consent that is upheld by any standard medical ethics piece of literature that you want to look at, whether that comes from the American Medical Association. They publish a book about medical ethics, whether it's the American College of OBGYN, which is the professional organization for OB-GYN doctors. They talk about ethics as well. And what informed consent really is a conversation. That's what informed consent is. And in this conversation, you tell the patient, or in this case, it might be the pregnant mother, what the different options are. So in the setting of VBAC, the options are going to be to try for vaginal birth or to plan a repeat C-section. And you discuss the pros and cons of both of those approaches. And then together with the pregnant mother, you end up making a plan about what the birth plan is going to be. And ideally, it's going to be driven largely by what the mother wants to do and her own personal values. So that is informed consent. It's a process, it's a procedure, it's a conversation. And then the paper is just a documentation of that conversation happened. So if you tell a woman that, okay, and this is at her 12-week, prenatal visit, and you say, I see that you've had a prior C-section, so we're going to go ahead and schedule you for 39 weeks. I got my calendar right here. We'll just pencil you in. And then the morning of the C-section, you say, oh, incidentally, by the way, there's risk of infection, organ injury, blah, blah, blah. And you do this quick thing, sign here, mom signs. And you walk in and you do the C-section. That is not informed consent. So there's some language in the ethics literature that talks about if the mother really was not given an adequate conversation, if she really does not have the choice to plan for a vaginal birth, then in fact that is not informed consent. She's signing a paper and it makes the institution feel comfortable, but really no informed consent ever happened there.
Yeah, and it seems to me that that's kind of the norm. It's all right, put your name on the dotted line, but yeah, it doesn't mean that a conversation actually took place. Okay, so that's a really good definition. It's a conversation.
Mm-hmm.
Did you gonna say something else?
I was just gonna piggyback on your comment about it being the norm, and that's absolutely true. These procedures become so ingrained into daily life that nobody really questions the appropriateness the appropriateness or the ethics of all of this. It's just, you know, you did it yesterday, you did it the week before, you did it the month before, this is how you did it last year. And it's just the routine. And yeah, in fact, when I have this conversation with community OBs, even OBs that I, you know, hold in high esteem, that are good people out there trying to do the right thing, when I frame this as an ethical problem, what I've experienced is they have a hard time conceptualizing this as an ethical issue, and I get a little bit pushback, and they'll say, you know, I don't really see this as an ethical issue. And then I push back and say, well, it's absolutely an ethical issue, because if women don't have the option for a vaginal birth, what that means in essence is that they are going to be forced to have a surgery, whether it's what they want or not. And in this country, people are supposed to have the right to choose what happens to their body and whether they're going to accept medical therapies or not. In this case, it would be a C-section. So if women don't really have that choice, what that really means is forced surgery. But you know, OBs are so used to doing it that they just don't view it as an ethical issue. It's just sort of day's work, all in a day's work.
Yeah, and you had mentioned this in a conversation we had, and I've heard this elsewhere as well, where it's like obstetrics is the only area in medicine where people are just routinely forced into surgery. You know, I heard someone say if someone comes into the ER with a gunshot wound and they don't want an operation, then they don't get one. And I feel like this has to be because of, you know, the danger to the baby, right? It's not just the mother deciding for herself. What do you think?
Yeah, there's you know, there's a culture in obstetrics, and there's this notion that when you're caring for the pregnant mother, you have two patients. So you have the mother and you have the fetus, and that you are ethically bound to care for both of them. And this concept, you know, on a certain level, there's some benevolence under that. You know, you want to take care of mom and you want to take care of baby and you want to do the right thing for both of them. And most of the time it's very easy because what's in the interest of one is in the interest of the other. So there's no dilemma there. The difficulty comes in when there's something that might be better for mom, or maybe it's better for baby, and then you kind of have to weigh, you know, pros and cons, and it becomes a little bit challenging. And there's something in the culture of obstetric training that weighs intervention on behalf of the fetus very heavily, to the degree that it may justify doing something to the mother even against her will, and that it's justified on the basis of, well, you know, the baby really needed me to do that. And there's probably a lot of contribution to this from the legal system as well, because if something goes wrong in a pregnancy and the baby comes out poorly, that potentially can lead to a very, very heavy lawsuit for the provider. So there's also, you know, fear on the part of providers. If, you know, if I kind of let this mom do what she wants, and then the baby's injured or something bad happens to the baby, the mom is not going to say, well, you know, thank you for respecting my rights and treating me ethically. The mom's going to say, I didn't know what I was doing. You're the doctor. You're supposed to make sure my baby turned out okay, and you should have done what you needed to do. And in fact, there are cases like that. So it really puts OB providers in a very tough position, and it just creates a lot of anxiety and a very strong incentive to make sure that they are, you know, intervening on behalf of the baby, or at least what in their perception is, you know, on behalf of the baby. So, you know, there are a lot of very powerful forces acting on, you know, everybody, that leads them to behave the way they do.
Mm-hmm. Yeah, well, and it's good to see kind of like the whole picture, because that's not something, you know, a layperson necessarily thinks about. Okay, so circling back to El Paso and how I know you. In fact, it's because you're coming to a training that I'm organizing on VBAC called the Truth.
Yeah, I'm excited.
Yeah, I'm really, again, really excited about this coming up, and that you're going to be coming. So just tell me a little bit about how you know Jen Kamel, who is the woman who's going to be teaching the training, and sort of what your expectations are.
Yeah. So I first met Jen at it was a conference in Los Angeles related to human rights in pregnancy and obstetric issues. So so obviously that's something that both of us think about a lot. We ended up meeting and having various conversations at this conference. Subsequently, I learned about VBAC facts. I saw her give a couple of presentations, and I have to say that I really I was floored by Jen Kamel. I'm a person that's very involved in medical education. I attend conferences all the time. I travel. I listen to the experts on a national and even international level talking about various medical issues. So there's a certain caliber of presentation that I'm used to listening to, and Jen basically is on that level. When you're when I hear from an expert, I kind of want to get the sense that they really know everything there is to know about the topic. Not that there isn't more to learn, but just everything that's been published. They have a command of the literature, and when you talk about medical literature, it's not a simple issue of just reading it. You have to then also assess it and analyze it and interpret it, because it's not a simple issue of facts. Studies vary in quality. There's different methods and sample sizes and all kind of things that you have to be careful and make a judgment about. Is this a good study? Do I believe what the results are? Is it in conflict with what the results of another study were, and why is that? And she's able to do that kind of in-depth analysis, so that even someone like me, who's an obstetrician and a high-risk pregnancy specialist, still have something to gain from seeing her presentation, because she really dissects things on a very deep level. So I've really come to appreciate that about her, and I count on her. If there's ever a specific question about some specific aspect about VBAC, I know I'm going to get an answer that's going to be something reliable and really supported by the literature.
Wow, wonderful. Okay, and so how do you suppose other maternal health care providers would benefit from this, and who else would you expect to see or hope to see?
Yeah, I think anybody that's involved in pregnancy in any way stands to benefit, and that ranges all the way from pregnant patients or pregnant women or their family members, into all types of birth professionals, doulas, midwives, OBs, MFMs. And the reason is, in addition to having a good mastery of the literature, she's also very good at teaching and presenting in an understandable way, which some people who are really expert in their field are not so good at presenting, and can present things in a confusing way or kind of a boring way, and you find yourself snoozing through presentations. So she is very good at breaking things down in lay kind of language, and she also alters her presentations depending on the audience. But it's her talks are useful for patients, because very often they have a hard time finding accurate information and they hear conflicting stuff. Sometimes I find a situation where the mother wants to do a vaginal birth, but somebody in the family is very concerned about it, and they conceptualize this as a very dangerous, risky thing to do. So it could be very useful for a family member to educate themselves and learn about this, and have a a more of an educated point of view rather than just a purely emotional and fear-based point of view. So for lay people, this is very helpful. For professionals in the birth world, I think it's helpful if you don't do VBAC and maybe you don't know a lot about it. That's just a situation you don't want to be in as a birth professional. I mean, really, your duty is to really know about your specialty. And I hear all kinds of misquotes and false statistics and myths being perpetuated even by OB providers. So, that does a lot of harm. Number one, then you're practicing in medical care that's not evidence-based, and that leads to maybe less than optimal outcomes, and nobody wants that. But number two, when people discover that something you have said is not true, that really undermines their confidence in you. And that is not something that you ever want. You want the people you're taking care of to view you as an expert. And then another problem that happens is not only is their confidence in you broken, it really undermines confidence in the medical specialty as a whole. And then people go, you go to these doctors and they tell you whatever they want to tell you just because they want to operate on you. And it really undermines the faith in the public in, healthcare providers. And so that's a really harmful, outcome that I think maybe these providers don't think about. And then you go all the way to the other end of the spectrum to people who do VBAC, who offer VBAC, who are there doing it every day. And you still, I think, have a lot to learn from Jen Kamel, because you can get into some of the more esoteric areas, like what about a short interpregnancy interval where the recent C-section was, less than a year and a half away. I hear a lot of myths about that. What if the mom has had more than one prior C-section? What if the mom goes past the due date? What if the baby seems to be, quote unquote, big? That's a whole, another conversation. But these are areas where even providers who offer VBAC, they have some confusion, related to what the science says and what the literature says. So even if you're already a VBAC provider, there are still things to learn from Jen Kamel. So I really think, anybody who is involved in pregnancy care in any way has something to gain.
Yeah, and I just want to add on, I guess, a little to that, where it's like, I think we tend to assume that, like, oh, doctors and midwives, and they just know, what the best evidence is and they know what's most recent. But I think it's like, it takes a lot of time to keep up with that. And then also, I don't think that just because you're a medical professional, that means that you necessarily are an expert at reviewing research. That's kind of a different thing. And then also, just for myself, one of the reasons I'm such a big fan of Jen's is because, I've done a few of her shorter courses, I've done her webinars, and I feel like if you attend this, like, you're just gonna be so much smarter about how to interpret it. It's like we see these headlines, study says, and it seems to just refute, what we knew to be truth about nutrition or climate change or whatever. That's because we have no idea how to interpret what's a strong study and what's not. So yeah, you're going to learn a lot about VBAC, but you're also going to learn a whole lot just about how to interpret those kinds of headlines in these studies that are constantly coming out and seem to overturn an entire body of evidence. But do they really? So that's just my little pitch. Okay, and so last question, Dr. Chavira, you are actually from El Paso, is that right?
Yeah. So my family's been there for a few generations. Even, on my dad's side, my grandparents were born there. So we've been there for quite a while. The family in my generation has kind of dispersed, so some have gone to other parts of Texas, and I ended up, my family, we ended up in California, but I still have some aunts and uncles and cousins there, and so I go back and visit all the time.
What end of town did you grow up in?
Well, I was a little kid, so I'm not sure exactly the neighborhood that I would call it, but it's more kind of on the east side and fairly close to the border.
Okay. Okay. Well, I excited to welcome you back and have you back here. And yeah, thank you so much for your time and all this information. Lots of food for thought. I hope everyone enjoyed it, and I will certainly be sharing this widely and broadly. Anyway, thank you so much.
Yeah, you're welcome. Thank you for having me. And I really look forward to seeing you in El Paso. And one final thing, if anybody wants to look me up on Facebook, I do have a Facebook page. So it's basically my name, Emiliano Chavira, MD, MPH, FACOG. Those are the degrees. So Emiliano Chavira, MD, MPH. You'll find me there.
Okay, and you know what? I'll add that in the comments as well on
Okay.
on the page here.
All right. I'll see you in El Paso.
Okay, thanks. Bye.